All right. Well, good morning, good afternoon. Just seeing everybody is logging in, but we'll go ahead and start our introductions. Please note if you have any questions about slides or certificates or CEUs, that's on the slide right here, but we'll be reviewing that as well. I'm very grateful to have everyone here today. My name is Christina Clayton. I'm one of the co-directors of the Northwest Mental Health Technology Transfer Center, and welcome to today's webinar, Grief, Exhaustion, and Finding Vitality in Behavioral Healthcare for Supervisors and Leadership with Dr. Mossov. We're very grateful that you could join us today. First off, we want to share our land acknowledgement, so we'll go to the next slide. And the Northwest MHTTC sits on the traditional lands and the unceded lands of the Coast Salish peoples and land which shares, waters with all tribes and bands within the Duwamish, Squamish, Tulalip, and Muckleshoot nations. Why we share this slide, which I think is even more important than me reading it to you, is that we just ask for those today in our event to reflect on the lands in which we all reside and acknowledge the ancestral homelands and traditional territories of Indigenous people. We want to take this time to acknowledge the land and pay respect to them and their homelands that were forcibly taken. And this calls us to commit to forever learn how to be better stewards of these lands through action, support, and education. So we'll put a link in the chat from Native Land if you want to learn more about the stewards of your land. And now we'll go on a little bit about the network. So the MHTC Network is a nationwide network supported by the Substance Abuse and Mental Health Services Administration. Our network includes 10 regional centers, and as well as a National American Indian Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. And there are corresponding networks for the addiction and prevention fields as well. So we support resource development, dissemination, training, and TA. We work with systems, practitioners, providers to deliver, effective evidence-based practices. And we span a full continuum of topics. So our region covers Northwest Region 10, which is Alaska, Idaho, Oregon, and Washington. And we're based in Seattle at the University of Washington in the Department of Psychiatry and Behavioral Sciences. Now, a little bit more about our mental health TTC here in Region 10. I'm going to go quickly because we want to get to the good stuff. So our goals are essentially to accelerate the adoption and implementation of mental health practices, heighten awareness, knowledge, and skills of the workforce, foster alliances and address training needs among diverse partners, and most importantly, ensure availability and delivery of free, publicly available training and TA like today. So how do we do that? Well, we have an area of focus for the network, which is evidence-based practices for serious mental health issues such as psychosis, but we provide training on a variety of topics. We offer our target workforce includes, anyone whose work has the potential to help improve behavioral health outcomes. And how do we fulfill our mission? On the next part, you'll see we do free training in TA. We'll see, we offer free self-paced online courses, live events like today, and we also post those, and we also do live virtual learning communities. And then lastly, we also provide newsletters, a resource library, research and practice briefs, and other on-demand content on our website. So to find out more, someone will put in the chat how you can connect with us, get to our website if you don't know already, and sign up for our newsletter so you'd hear about events like today. The next slide talks about some language. And so we always want to be mindful of using language that promotes recovery and culturally appropriate terminology. And we encourage everyone to use language that demonstrates respect for person's dignity and worth. And we want to just acknowledge that. And next we'll talk about some logistics. Due to the large audience, all of you are muted and you're not appearing on video. As noted in the beginning, this presentation will be recorded, and the recording and the slides will be made available on our website in a few weeks, and you'll receive an email where you can find these resources in a few weeks. And also, if you would like a certificate of attendance, they aren't formal CEUs, but there are certificates of attendance available. You get a separate email in a couple of weeks on how to access that if you would like. For the next slide, we'll talk about how you can communicate with us. So chat we have Q&A. So the chat is really, if you have technical issues, need assistance from our team, you want to say hi or share your location, or if you're having trouble with a poll. But for the next part, for Q&A, that's where we're going to ask that you have content related questions that you want Dr. Mossov to respond to generally at the end of the presentation. So if you put questions in the chat, we can't move them for you. So we might ask you to do that. Pardon me, I'm in a mildly public place. So if you're hearing background noise, I apologize. That's remoting. But anyway, so our team will moderate and share questions with the presenter. And if possible, we might share a short written response if need be. Lastly, your feedback is crucial to our work. And so we would really appreciate your response to a very short survey that takes just a few minutes after the session. We'll share that in the box today and by email tomorrow. It's required of our participation and it demonstrates what we do, but it really does help us evaluate our sessions and tell the speakers how it went. Off. And then lastly, our disclaimer. So SAMHSA provides support for this work, but this does not reflect their official position on any of the content. Now, the important part. I'm very, very grateful for our speaker and our topic today. And we might post some things along the way that might be of interest to you. But first, we're going to do a couple of polls. So I think Gabrielle will probably launch those at this point. Okay, so we're just asking to choose the best option that describes your role. I know you can't see the results, so I'm playing some sort of race narration here. So about a quarter of you are in behavioral health clinician or therapist roles. About half of you are clinical supervisors, given today is on especially supervisory and leadership topics. That makes sense. Let's see what else. Okay, and you're answering, I think, the settings. So we also have, you know, easily over half working in a behavioral health clinic. And those are those two questions. We have quite a number of you here today, so we're very excited. So I think we're getting real close on participation. Thanks for chatting in the other things that don't fit. We have only 10 options for each of our questions. All right, we got about 75, 77 participants. Give it another second or so and we'll see how it results. Looks like it's staying pretty similar. Okay, Gabriel, let's go ahead and roll on so we can get to the content. All right, so you can see what we have there for results. And when you're ready, you can close out the results by pressing the little X in the corner. All right. So I think, are those the only polls we're doing right now, Gabrielle or Kira?
I think right now, yeah, we have some content related polls for later.
Perfect. Excellent. Okay. Well, now it is my pleasure to introduce Dr. Mossov. She is a fan favorite around the MHTTC land. I will say we first got to know you when we were looking at provider well-being last year. We had a special supplement for that, and that was just a really wonderful connection. So Dr. Mossov is a practicing clinical psychologist, splitting time between seeing patients at Snohomish Psychology Associates, teaching as a senior instructor at Seattle U, serving as co-lead for the behavioral health strike team for the Washington State Department of Health. So she's just really sitting around eating bonbons, as we say. Her work and research interests focus on resilience and recovery from trauma, as well as disaster behavioral health. Worked abroad extensively in disaster response and first responders and healthcare workers throughout the United States. Dr. Mossov also conducts training and provides presentations to organizations and educational groups about disaster preparedness and resilience building within local communities. So you can see why we thought she'd be a great person to bring back for today. So now it is my pleasure to have a little bit of conversation with Dr. Mossov before we get going. So I'm going to go ahead and stop sharing. Maybe we could stop sharing our screen, Gabriel. That way we can have a little more time to just see some faces. There we go. So Dr. Mossov, thank you so much for being here today. Very, very grateful for your time. You know, when we approached you and said, hey, could you do another webinar for us? We're feeling like we need some of your wisdom. Some of your information has just really stuck with our team and those that have attended your previous webinars and podcasts and that sort of thing. So when we were discussing what topics seem crucial right now, you immediately shared this one, and that really made sense to me. As we enter year 3 of the pandemic, what are some of the important contextual factors to keep in mind as what are influencing, you know, how we're feeling right now?
Yeah, I mean, I guess the answer to that question, first of all, good morning. Hi, everybody. I'm so happy to be here with you all today, and I appreciate the opportunity to have some discussion and share some information with you about what it is that, you know, from a sort of disaster contextual recovery perspective, we're struggling with in behavioral health. So it looks like from the poll and from the conversation in the chat that everybody who's here today is deeply involved in this kind of work on a day-to-day basis. And the impetus for the topic and the reason why we kind of went in this direction was really based on my own conversations with my colleagues and talking to people. I'm seeing clients, I'm working with patients in a community setting, doing a lot of the COVID relief work as well. And the theme of grief and the theme of trying desperately in many ways to sort of transition our thinking from the pandemic as a disaster into what is recovery and what does the long term look like? How do we reconnect with the things that are invigorating to us as providers when it has been so stressful for such a long period of time and the level of exhaustion is so high? So the underlying sort of reasoning behind this theme and this topic today is really that I recognize in my own practice and my work and that of my colleagues that there is a necessity. I'm not going to say it's optional. I'm going to say it's a necessity for us to talk about the losses and the toll that has been taken over the last couple of years in order to effectively turn the corner and work through what we've experienced so that we can effectively re-engage. I don't think it's going to be very likely that we're going to find a lot of vitality unless we can appropriately work through. As you know, behavioral health folk, we understand the value in that, right? We need to work through what we've experienced in order to sort of move forward to a healthier degree. And I think that's what we'd all like to do. So that's where the sort of topic about grief and vitalities, the seeking of vitality in reconnecting with our work came from.
That's really helpful. And yeah, it's so much of what you share is so relevant, and you're hitting, you know, I think the pulse of what everyone is feeling right now. And it's been, you know, I remember when we first met, you know, it was sort of what wave were we on at that time, but it's now just countless waves and how many other things have happened. You know, what have you seen and heard about how all of this is affecting supervisors and leadership? Because, you know, having my own direct service and management and supervisory experience, it just seems like the field was already pretty difficult. And I think COVID has enhanced and shined a light on all the disparities that, you know, are in many aspects of our lives. But supervisors and leadership, you know, it wasn't an easy go before. Nor is it for direct service staff. I don't mean to take away from that, but I think for supervisors who, I heard once, you know, you get pushed up the nonprofit ladder, and I can completely empathize with that, and that you may not be prepared. So what are you hearing right now about how all of this is affecting leadership and supervisors?
Well, number one, I just want to acknowledge that the degree of burnout across everybody in healthcare professions and in education. So the extent to which your role may be combined as a leader, kind of providing support and educational, not like pedagogy to people, but educational support, training people maybe, as well as direct service and operating in a supervisory capacity. Like that degree of burnout is unlike anything any of us have ever seen in living memory. So the way that the complexity of the pandemic and the length of time has built upon itself to add to stress has been a very unique set of circumstances. That's number one. But the second thing is that the leaders that I've been speaking to over the last several years have really been in a position where they feel like they're on this tiny little balancing point of helping manage other people's experiences, overseeing from a business perspective, like what's the best thing for my team and how to manage the business goals at hand. And then the other thing that's constantly pulling is that you're not immune. You're not on an island from this. You have your own family situations. You have your own financial or job stress that's separate from the actual obligations that you have professionally. So people in leadership are actually being pulled in an additional set of directions potentially, which has added to some of that burnout that I was mentioning a second ago. It's very, very complex. And I want to acknowledge that leading through crisis is, it's an exceptional task for people, and it requires an exceptional level of perseverance. The fact that you're all here, the fact that you're all working on this as we move forward kind of collectively, it says to me, a great deal about the commitment to the work that you've already done. And it's really, really essential for leaders to recognize the power in, and I would say mission critical element of taking care of yourself so that the people on your team see you doing that, the power of social learning and modeling, and the necessity for leaders to show good boundaries and to have clear, healthy, resilience oriented behaviors just for your own sake, right? That the trickle down effect is that your team and the people who report to you see that and do that as well. So it's really, it's complicated. And I think that being pulled in an extra level of a different direction complicates things for people who are in leadership positions, for sure.
I could be asking you questions all day. There's just a couple more I want to try and get in before we get into the other content that I know you have. How do, in your experience, how do issues of equity and inclusion affect, grief and vitality, with so many communities experiencing before COVID, historical trauma and oppression, inequities and societal disparities, but also I imagine every community, every person has unique strengths and resources. So I guess I'm wondering, in all the work you've been doing, how do you see equity and inclusion and those sort of issues coming into play right now with trying to survive a third year of this pandemic?
Yeah. Well, I mean, something that I think has been very clear for most of us since the beginning is that the pandemic has been highly disproportionately impacting certain groups. So marginalized communities and groups and communities who have experienced systemic racism and discrimination are entering a disaster situation in terms of an impact from a different perspective, right? There's a different set of social and cultural experiences that go with that, which complicate things. So the answer that we give in clinical psychology is that it all depends, right? But what you were mentioning a second ago about unique strengths and resources, that's absolutely true. It's not reasonable, I don't think, to make a blanket generalization that it's harder or easier. I think that there are different sets of opportunities, but I also think that when you're coming in with systemic challenges that other people don't experience, it can be certainly additionally challenging. But at the same token, there might be resources and strategies that you have already honed and brought to bear on your experience that can help you with additional adversity. And it's not a math problem. It's not like A and B equals something. It's much more complicated than that. But I've been asked this question a lot when it comes to serious mental illness, because the research shows that with serious mental illness, diagnostically, in general, people tend to do a little bit worse after large-scale disasters. And that's not universally actually true. More updated research is showing that sometimes people who have highly developed coping skills and strategies and a plan that they already use were able to enact that plan when it got really, really rough. And other people who had never had a plan before because they hadn't needed one were at sea and didn't know what to do and where to start. So it's a parallel, but they're not obviously the same thing. When it comes to issues of equity, we know unequivocally that the pandemic has not been an equal opportunity disaster. It has certainly shined a spotlight, as you mentioned, on inequities that existed previously and exacerbated those in terms of resource allocation and the idea of just the interaction with the medical community in general, people interpreting correctly symptoms, and the medical community acknowledging what people are actually really reporting. That has been a big challenge. We call it sanctuary trauma, the idea of going to the doctor and not being believed, that kind of a thing. That is a symptom of a bigger inequity issue for sure. So there isn't a simple answer to that question, but
of course,
I think it complicates
we have to.
it. Yeah.
Well,
Right.
and this dawns on me just a flash while you were talking is, perhaps for some of us, or any of us that, certainly we can't know everyone's experience. There's no way to do that. But I think to just acknowledge that, imagine this stress that everyone is experiencing is just a little insight into what just constant stress from any number of things that are happening. And so I think that's a fair point that you're sharing. It's just, it's highlighting disparities. This is certainly true in the behavioral health and mental health field. We know there's a mass exodus and the great quit and all of that. So that's just especially hard on supervisors, but also who has to stick around, who is getting the brunt of all the work and the stress in the field.
Yes.
So let's end on perhaps a light at the end of whatever tunnel we're in. I'm not sure anymore. But given your experience and your specific work around these challenges, what gives you hope? You've hinted at that, but what gives you hope that we can put a path forward towards vitality despite all of these things happening? Because I know you've done this work for a long time, and you remain hopeful, and I'm excited to hear about that today.
So we are going to talk a little bit today about reconnecting with core values. And I'll start by saying that hope is the most foundational of one of my core values. It's the thing that I balance things on, basically. And hope for me is really based on a lot of the experience in disaster work that I've done that you're mentioning, where the reason why I know we're going to be okay is because that's what we are. That's what we do. That's what people do. And I haven't lived through a pandemic either, but I can tell you that in any combination of critical incidents and disasters on large and small scale, underlying and I should say overlapping discrimination and marginalization and inequity, humans are incredibly capable and incredibly resilient. And that is fundamentally part of our baseline DNA for all of us as human beings. And so it's challenging to bring that to front of mind when we are going through another quarantine and someone else quit and the budget just got cut. However, at the end of the day, the tiny little interactions that we have with each other professionally and personally really, really matter. And at the end of 30 days or 60 days or 90 days, things will look a little bit better and a little bit different than they do now. And I believe that fully. And that's part of why I enjoy speaking about these things, is because I don't think, that's what the research shows, but it's also stuff that I've personally witnessed in terms of what humans are capable of. So it's very reassuring to me.
Yeah. Well, thank you so much. Very, very excited always to talk with you. And, thank you so much for this informative conversation. It's always great to speak with you. We'll let you get into your material. I just another a shout out for folks. We're always short on time, but please put your questions in the Q&A box. And if we don't get to them live, we usually always produce a sort of Q&A and resource document after each session, so we can at least get Dr. Mossov to help answer. And then we'll share that with everybody when we're done. But we'll let you take it away from here. Thank you so much.
Great, thank you. Okay, I'm going to go ahead and share my screen. I will make sure to answer the questions in the Q&A as I get done. So I'm keeping an eye on those up there, and I will definitely address that. I appreciate the question about sanctuary trauma, because that's certainly something that has come up a lot in the context of the pandemic. And I think it's a really, really important thing for us as providers to keep in mind, for sure, and try to deal with in a way that really benefits the clients and the patients that we're serving. So our agenda for today, I'm going to try and cover 5 topics fairly briefly in our time together, but please ask questions if you have them. So the first thing is just a snapshot about why the current conditions create the functional challenges that we are experiencing right now, kind of what's going on there. The second one is about how the neurology of information and emotional processing impacts our leadership and the ability to make good decisions in crisis management. I'm going to talk a lot about grief, loss, and bereavement because, as I mentioned at the very beginning, I believe that addressing that and processing through it is a necessary piece of our collective recovery. I'm going to share some best practices for management through crises, and then talk about where to go with vitality. And we're going to talk a little bit about core values at the end today. So I'm going to start with this chart. This is a graph that SAMHSA created years ago to describe and sort of define the different phases of experience that people have in large-scale disasters. So, you know, any disaster, whether it's a hurricane or a tornado or a flood or what have you, this is the typical pattern. And it doesn't, you know, it doesn't look exactly like this, but we go through these phases in a very, very well-known and understood way. So the pandemic is really not different from that, except for the fact that what we're in right now is called a disaster cascade. So this is a updated version of that chart that I just showed you, but it's for COVID specifically. The secondary impact that we experienced was the Delta variant. The third impact was from Omicron. Now, depending on where you're joining us from today, like where you might be calling in from, there might be a different set of timeframes that goes with this. There might be wildfires, there might be floods, or different kinds of storms that created additional large-scale impacts. So for Region 10 in general, and for Washington State, this is sort of a snapshot that's a little bit more narrowed to that geographic area. But in general, we are nowhere in this country, or even most of the world, not in a disaster cascade at this point. So a disaster cascade is defined as more than one large-scale impact within the same window that it would take us to recover from the first impact. So usually, if we are left alone, if human beings get the opportunity, we get to our baseline between 18 and 24 months from the original impact, usually around 20 months. So less than 2 years. We're back up to whatever we came into the pandemic with in terms of symptoms and experience and coping skills, right? The Delta variant secondary impact was for this area, August and September of 2021. And then Omicron was December and January. So again, those timelines are different in different parts of the world, but in general, what you want to keep in mind is that one of the reasons why there is so much compounding stress right now is because a disaster cascade taxes already depleted resources. We are already mentally exhausted or emotionally somewhat compromised, and we are struggling to make good decisions and to navigate social interactions appropriately, especially from a leadership and an operational lens. And the reason why it's so hard is because look at how low the baseline got. Like we already are experiencing stress beyond what we normally would. And under the current conditions, it's almost exceptionally harder. Now you add that with the time of year, the holidays coming off of, the holiday season and into the spring. And you can really have an understanding of why the Great Resignation and the levels of burnout really are as high as they are. So this is the general landscape. The one thing I want to leave off on this slide that before I move on is to note to you all that eventually people will get back up to that baseline, into that place of resilience. Resilience remains the most common outcome for any series of disaster cascades. That is sort of the baseline for the human response to disasters. In COVID, I anticipate that those numbers will be in the 50 to 75% range, which I know is a huge variation. Maybe I'll aim towards 75%. So 75% of folks are going to get back to baseline and have that experience of resilience at the end of the day. Now, that might be way longer down the road than we had thought originally, but it will still happen. And this includes kids as well. There are other behavioral health outcomes that happen with disasters too, from increased symptom acuity to new diagnoses, onset, new incidents of disorders like major depressive disorder or anxiety or PTSD. And then there is also something called chronic dysfunction, which is an option, but it is the least likely of all of the options. Resilience remains the most common outcome. So what does this all mean in terms of leadership? It's really helpful, and I'm sure most of you know this already, but a basic recap on the relationship between stress and trauma, right? So all trauma is stressful, but not all stress is traumatic. It doesn't go both ways. To use another metaphor, right? All ducks are birds, but not all birds are ducks, right? All trauma is stressful, but not all stress is traumatic. So stress can build up And certainly the degree of stress that we have been experiencing over the last 18 to 24 months has been moderate to severe in many, many cases. So moderate to severe long-term stress can look and does look neurologically almost exactly like trauma. So you can have a singular traumatic incident, or you can have in your, a buildup in your brain of cortisol and different chemicals and things, where your fight or flight system has been activated so much that neurologically it looks very, very, very similar, if not almost identical. So where we are after 3 large-scale impacts is in this highly activated, limbic system oriented brain place that looks like moderate to severe long-term stress and or trauma for most people. So our brains are entering into professional and personal relationship with other brains from this perspective. And that has challenges and certainly creates some issues for people. It was mentioned, I think I saw something in the chat previously about secondary traumatic stress and how it used to be something I think that we talked more about. It has not been talked about as much with COVID. Not entirely sure why that's the case. It is absolutely an issue. And for people in leadership and supervisory positions, you're dealing with it on multiple levels, right? So you're dealing with secondary traumatic stress from clinical encounters, right? But you're also hearing the personal stories of the people that you are supporting on your teams, like what they're going through with their family members or their children. And then you're also dealing with your own, whatever's happening in the background, right? Whether that's isolation or whether that's separation from friends and family, or whether that is some additional crisis that you're managing on your own as well. So it's so multifaceted in terms of where that additional trauma and that additional stress may be coming from for supervisors specifically. The example that I have in my mind that I've seen a lot in disasters is that you have a group of people, and I would put us all in this sort of collective category today as we're participating together. It's this sense that on your teams at work, there's one life ring and everybody's treading water, and you just keep tossing the one life ring to each other from person to person and person. And then you get your minute with the life ring and then you have to pass it on because the resources are so scarce. There aren't enough people. There's not enough budget. There's not enough time in the day. And you have to just keep passing on the help. And then you get your little, maybe a moment of rest or breathing, and then you have to pass it on again. So that takes its toll. And especially at 2 years heading into a 3rd year of that, people can do that. You can tread water for a while, right? But eventually, it goes into what we call degradation of care. And degradation of care is a phenomenon that happens in every disaster, regardless of what type. And it just basically means that the way we interact in terms of caregiving is different than it would be in a non-disaster scenario. Degradation of care doesn't necessarily mean worse care, right? It means that maybe you're not able to see as many people. Maybe you're not as able to spend quite as much time. It doesn't mean that the quality is actually degraded. It means that the conditions under which the care is being given are different than they would be in a sort of normal operating environment. And it's when resources are scarcer. So staffing ratios change and schedules change and certainly budgets change. And as I was mentioning at the beginning, the specific context and viewpoint of leadership is the idea that all the pressures are coming from every direction. It's not like there's a direction that doesn't or might feel less threatening. It's that you're getting it maybe from your family and personally and from top down and bottom up. So yeah, it's very, 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 very challenging. I just want to acknowledge Anne's comment in the chat about, if you're the life ring yourself and you feel like you've sprung a leak. I use a lot of metaphors when I talk, but you can't pour tea out of an empty teapot, right? And if you feel like you're constantly giving to others, then somehow your pot has to be refilled, because what happens when there's nothing left to give? Yeah. And that's a question that many of us are faced with right now. Oops, sorry. So I've shared this slide in previous webinars, but it's worth a very brief review. So when our limbic system has been so highly activated for so long, there's 2 things that happen. Number one is that we tend to misperceive information. We tend to focus on what's not getting done, on any potential threats, on anticipating what might be negative so that we can defend ourselves. Our brains are programmed to keep us alive and to keep us safe, especially in these long-term disaster cascades. So we misperceive emails and text messages and somebody saying something as they pass us by in the hall. Our brains are so programmed to try and defend ourselves to keep us safe that we're perceiving things as negative or threatening or hostile, even if they might not be. That is very, very important to understand when you consider how you're operating in your work environment, right? Just to give yourself a break and to recognize, okay, I'm more likely to, and so is everybody around me, be responding in such a way. So how can I adjust my responding, take a little bit more time before I engage with colleagues and with team members so that I'm checking that limbic response, because we're all there naturally. And then the other thing is the prefrontal cortex, which is the part that's, logical and reasoned and considers all the details and helps us focus and track things. That isn't really online in the same kind of a way. It's there, but it is not necessary for survival neurologically. So it might be kind of hanging out in the background, and it might make it so that it feels like you're extra compromised when it comes to making good decisions and regulating your own behavior and, considering consequences for things. You're just not thinking maybe as rationally as you should. And please note that this same phenomenon is occurring with other people on your team. So you might be seeing that behavior in other people and being like, where are they coming from? Like, why are they acting that way? Or why are they thinking that way? That doesn't make any sense. And it might be that they're not coming from a logical perspective, because that's kind of where our brains are right now. So I'm going to switch gears and I'm going to talk a little bit about grief and loss. And I've said a couple times now that working through and acknowledging grief and loss is going to be a necessary piece of our recovery. And I want to start by reminding everyone, I'm sure you all know, right? But loss in this pandemic is not directly about the loss of a loved one necessarily. If you have been fortunate enough to have not lost a loved one in this pandemic, either directly from COVID or just from other circumstances, right? I'm guessing that you still have had some degree of loss or grief around something. Loss of an identity, loss of a sense of security, loss of sort of empowerment over the choices and things that are happening in your own life. All of those are things to acknowledge in grief. And chances are is that when you do experience, and any of us experience a loss right now, it is touching on a deep well of loss that's been building over the last 2 years. So our emotional response is likely to be stronger right now. That plus our limbic systems are more activated. So as we're working through, again, from a leadership or supervisory perspective, and you can apply this personally as well, if you're talking and supporting and working with someone who's lost someone, right, directly, using that type of loss for this example, even when things are happy, there's a sense that someone's missing. And small talk can be painful. It can feel so meaningless and very, very difficult to get through. So superficial. Grief is often very awkward. No, people don't really know, like, do I ask directly about that and how they're doing? And it really is okay, right? It depends. There are significant cultural differences in how direct it is appropriate to be in asking about a loss. But if you don't know, it's usually okay to ask as well, right? That's part of how we respect cultural and communication differences in communication. And then recognizing that emotional regulation, because it's all over the place anyway, is a challenge. But you might find yourself not emoting when you expect yourself to be. And then you see a cat food commercial, or you're just drive past a certain building and all of a sudden it feels overwhelming in terms of emotion. That's okay, because that's part of how we process through. It might really sneak up on you and surprise you. Grief really comes in waves too. So it might be, a good week or a good day, and then a really not so good week or not so good day as well. I wanted to add this slide because it has been discussed a lot amongst my team and my colleagues about this idea of directionality with support. And it's really challenging to do this because everyone, like I mentioned, everyone has had some degree of loss over the last 2 years. However, as we are trying to provide support, this is just a helpful thing to keep in mind. When you're having a one-to-one interaction with somebody else, whether it's personal or on your team, keep in mind that it goes one way. So you are providing comfort more closely towards the center of these circles, like right to the person who's directly affected, and they are allowed to express distress out. It doesn't go the other way, whereby you put the person who's directly associated with the loss in a position to comfort you. That is something that happens quite a bit. And part of the reason it happens is because we don't we're so uncomfortable dealing with grief and loss that we really aren't sure how to navigate that very well. And I also want to acknowledge that with COVID, because everybody has experienced some degree of loss, right? It's not these simple circles. It's not as simple as this, but try to keep in mind that for individual one-on-one interactions with someone else, try to identify for yourself, who is the person most directly affected? Am I doing the comforting, or do I need the comfort? Which direction is this going, right? But if you're the one doing the comforting, just try to remember not to put the person in a position to support you. I've had many clients and patients and students actually talk to me about acute grief that they were experiencing. And when someone came to support them, it felt like they needed to just comfort the other person, and it felt very uncomfortable for the person who was grieving. So this is just something to keep in mind. Considerations for working with this in general. I just want to mention 2 things off this list. I don't need to read the slide to you, but it's really helpful to not make impulsive decisions. Because our limbic systems are so activated, we really want to encourage people to take a moment before making any life-changing decisions. So if someone says, you know what, I can't handle this, I'm going to sell the car, sell the house, and move to, I just say Brazil, but wherever, right? It doesn't matter. And that's a huge life change for them. I would encourage you not to naysay it, even if it sounds a little bit crazy. Just to give it a moment and say, okay, you know what? If that's what you want to do, we'll work through that, but please give it several weeks to a month. Like, wait for now. And if you still feel that way in a few months, then we'll work through it at that time. But encouraging people to give a window of time to get a perspective on the thing, get your whole brain involved with the decision, is always a helpful deal. The other thing I want to suggest is that I would guess everybody on this webinar today has at some point said, let me know how I can help. When you're trying to offer support to someone who's grieving, let me know how I can support you. Rather than saying that, what I would recommend is to consider identifying a discrete and specific concrete thing you can offer that you can allow the person to say yes or no to, right? So you're not putting the onus and the responsibility on the person who's grieving to come up with something. You say, can I bring a hot meal and drop it off on your porch? Can I take the kids to the park for you? Can I get the oil changed in your car? Can I take care of a piece of business? Can I get some groceries delivered, or whatever the case may be? Offering a discrete task that you can take responsibility for and giving them the chance to say yes or no. And then active listening. I'm quite sure that everybody who's participating today is aware of what active listening is, but I can't overemphasize it, right? It is the most helpful large-scale disaster support intervention that we have in our entire toolbox. And it might not be as concrete as CBT. It's not as maybe nuanced or elegant as some of the other types of interventions, but active listening is incredibly powerful. And we know that it works. The research bears that out. So it's the thing. I'm going to share with you now briefly a model that I developed to keep in mind certain takeaway points from managing through grief. So this is about just acknowledging, first of all, that much of grief and loss is not specific, although often it is, but it's not always about the loss of a person or the death of a loved one. It can include the loss of identity, the loss of meaning, the loss of an idea or principle because of a shift in worldview, right? And certainly what we've experienced in the last 2 years has shaken that up quite a bit. It's really, really challenging to see. So the heal model is about recognizing that there's no right or wrong way. People are going to process grief differently. There's no specific time frame. The elements are all interchangeable. There's instant stages that you work through, and then it's not meant to be a competing model for stages of grief, right? But it's about recognizing the common elements that humans tend to experience. Okay. I'll start with honor. So H is for honor, and this one is about, first of all, maybe putting pen to paper and recognizing what it is that the loss really represents to you, acknowledging concretely as much as you can what it is that you might be grieving right now as a person and as a professional. Honoring the loss means participating in rituals or identifying traditions, culturally appropriate traditions and ceremonies when they exist that can help work through this, whatever that may look like, rather than avoiding things, but really recognizing what are the pieces of my experience over the last 2 years that I need to honor that I don't get back. One technique for this is doing we're just writing on a piece of paper, something I have lost is blank, something I have gained is blank. And this is an exercise actually that the faculty at Seattle U did. And it was incredibly moving. Just acknowledging something I have lost in the last 2 years is blank. Something I have gained is blank. And just working through that. And you can do that with your team members as well. Oh, sorry. One last thing about honor. It is really important to include children in this process at a developmentally appropriate level. One of the biggest mistakes that I see as a disaster responder is that adults try and protect children by not giving them information to help them work through the loss, whatever it may be. So please do include children in a culturally appropriate way, right? Whatever that looks like, but don't exclude them in an attempt to protect them, because often children make up things that are worse than what has happened, and they blame themselves, or they may blame themselves. So giving them appropriate information is really, really important. Yeah. And coming up with ways to honor losses when we haven't had the ability to gather in the way it requires a high degree of creativity, and it does take a community in many ways. We haven't been able to honor losses the way that we want to, but that's a really important consideration too. Trying our best to work through that. The E in HEAL is about expression. And what I want to emphasize here is that anger is a bodyguard emotion. So anger protects us from feeling other things like sadness or fear. Anger is very, very easy to access neurologically. It's right there on the surface, right? And anger is seen honestly as being more culturally and socially appropriate. Like, it's okay to be mad, but it's not as okay to feel sad or to be afraid. And so when we're working through grief, a lot of things tend to be expressed through anger, when in fact there's something else that's deeper going on underneath. Yeah, I want to acknowledge Katrina's comment in the Q&A. The honoring the loss can happen at any point, right? It can happen down the road. It can happen immediately. There is no time frame for it. It does need to happen, and that's why it's included. But if you are unable to address it or deal with it directly and immediately, then it's absolutely appropriate to wait and taking time to identify how that works for you, for sure. So when we think about emotion and we think about emotional expression and anger, often people might find themselves feeling very, very angry towards someone they have lost who has passed, and then feeling guilty because they are angry, right? So a lot of things are coming out through anger, and we need to acknowledge and recognize for each other why that's happening, and that it is very, very normal, and then engaging in active listening to try and find out what's driving it underneath. Anger very, very rarely represents what it's seeming like it's representing. It almost always is doing something else in terms of an emotional stratification. Okay. The A in the HEAL model stands for acknowledging the obstacles. And honestly, with COVID, the thing that I hear all the time, and I'm sure you do as well, is but if then. If COVID hadn't happened, then if they had gotten vaccinated, then if we hadn't had the vaccine mandates, then, right? If then, but if then, whatever the position is, whatever the socio-political perspective, right? The but if then keeps us stuck. And there's no fault to be had in that. That's the normal human response. But acknowledging what's blocking you and what's keeping you stuck is one of the things that helps movement and helps recovery. So if you notice yourself saying, but if then one of the simple clinical guidelines around that is to say, but it just did. And that is absolutely an oversimplification, I acknowledge. But it's a place to start, because you're checking yourself in your automatic response, for sure. So common obstacles, avoiding it didn't happen, wishing it was different, the if onlys, and then what could I have done differently to prevent this? And at the end of the day, coming back to, but it just did. But it just did. Yeah. Another answer I want to address as we're on this topic in the Q&A is Katrina's comment about requiring someone to identify a gain. We don't want to be requiring anything, right? Because people's processing speed and where they are chemically, neurologically, emotionally, all of it is so different. We don't want to push someone, even in a therapeutic setting, right? You don't want to be pushing someone to identify, what have you gained from this? What have you learned from this too soon after a loss, for sure. Okay, and then the last element of the HEAL acronym is to live. And starting with just breathing every day, getting up, and maybe not being very connected to things and feeling like you're kind of in a fog. That's incredibly common. But transitioning slowly from just existing and just breathing into connecting again with things that are outside of yourself, right? Other things, other people, other motivators, and shifting focus to re-engage. That's about really truly living again. That time frame is not specific. It's not 1 year, it's not 6 months. That can happen quickly for some people, and it can take a long time, years, in fact, for other people. So it's meant to be a little bit aspirational, and it's meant to be included here just because that's an important component to healing and recovery in general. But when it happens and how it happens, totally different for everybody. Yeah. Okay, crisis leadership considerations. I'm going to shift gears again away from grief and loss and talk about, specific, in your mindset as a leader, like what are some considerations for whenever the next thing happens, whether that's hopefully not another pandemic or another variant, but things that come up, whether it's a small scale incident or it's a large scale kind of a thing. There are 3 common failure points generally in crisis management. Number 1 is not being clear on who's in charge of what. And COVID has given us a lot of opportunity to work this out. I would strongly encourage all of you to consider moving forward into 2022, getting a very, very clear crisis management plan in place if you don't have one already, right? So that there's a clear structure about when things go sideways, who's in charge of what decision making. Even if you end up changing it, identifying who is, from an authority perspective, responsible for various aspects of the team, of staffing decisions, of scheduling, that kind of thing, having that really, really clearly identified is important. The second thing is communication. That means very, very good planning and implementation around how messages are going to be disseminated throughout your group, whether that's a small work group or your organization as a whole. Who's in charge of doing that? And what is the protocol for how messages are going to be released? One of the biggest mistakes is that it's just all over the place and that it's not consistent, and people don't know when they're going to get messaging or what that's going to look like. And then the third failure point typically is the expectations for staff members, for supervisors, for people at higher executive levels. What is expected? And can we get that in black and white, get it really organized for folks so that it's clearly delineated before you go into the next crisis, for sure. Positive coping strategies are always recommended, and not mandatory group debriefings are not recommended, actually contraindicated for team recovery from disasters. So no group debriefings, especially not mandatory group debriefings, absolutely should be avoided. The research shows that actually can be harmful for people, but leadership should and could and should model positive coping strategies. How is an active coping plan going to be enacted here that I can demonstrate? Rachel, I see your hand is going up. I'm going to take Q&A at the end, so I want to try and come back to that if I can, unless you have a tech question. Anniversary effects. What I want to say about that is that it's a bell curve. So some people are going to be strongly impacted by the 2-year anniversary heading into the 3rd year of COVID, really. And some people are going to not even notice that it's happening. And so you don't want to overemphasize it, like make a big deal out of it if it's really not. But you do want to acknowledge it for the people who are going to be experiencing some, pretty challenging setbacks because they're being reminded seasonally or just in terms of time about certain markers of things that here we go again with another year of this pandemic. So there's a middle ground approach. It's not overemphasis and it's not ignoring. And then another crisis leadership consideration is just, we spend a lot of time in survival catch-up mode. Just what do we have to do right now to put fires out? I would encourage you to try to structure some time in your schedule to sit down and think about where it is that you want to be going, regardless of what the business parameters say you can do in terms of staffing or budget. Think about where you want to be going, because having an idea about your goals for the big picture are going to help you identify the small concrete steps in order to get there. You need to do both. You can't just be focused on right now, and you can't just be focused on post-pandemic, right? If you have a little bit of both, it allows you to navigate and create a pretty good roadmap, I should say, for yourself. Yes, I'm looking at the questions in the Q&A. I can't wait to address them. Yes. Okay, best practices in general. On the people side, you want to be transparent. If you don't know, say you don't know. The research is completely clear on this. It's much more effective for leadership to say, I have no idea, but it could be A or B or C. We'll see, rather than not saying anything, playing it close to the vest and leaving people to wonder about things. So being transparent is key. Modeling and leading by example, and not just talking about good boundaries, but actually not sending an email at 2 o'clock in the morning on a Saturday, right? Modeling the healthy techniques, the active coping skills, and the boundaries that are so important for long-term recovery. Building in structural support. That means time in a meeting agenda to call out thank yous and kudos and acknowledgement of success. Because our brains aren't focused on that right now, one of the most helpful things a leader can do is to build agenda time in to acknowledge effort and success. I would say not just success, but effort. Effort is key, how hard people are trying right now. On the business side, continue to develop contingency plans. Preparation is the best type of recovery for disasters. Clearly prioritizing what it is we need to do next. What is the number one priority, second priority, et cetera. Don't just revert back to the old ways of doing things, but reorient around what's reasonable for this next phase of the group, the team, the organization as a whole. Don't just fall back on things because that's how it used to be, right? But be thoughtful about what can we leave behind intentionally, and what are some processes and procedures that we could develop in a new way. And then continuing to include behavioral health as part of overall health in general. It's not on the side. Okay, I think I'm going to wrap it up here and then we'll do Q&A. This is another acronym model that I developed to really summarize the recommendations for reducing compassion fatigue and some of the secondary traumatic stress that we are experiencing. Number one is to reward yourself for a job well done. Build in positive reinforcements that are healthy, right? Be careful that a reward isn't like a bottle of wine, right? But if you want to have a glass of wine on a Friday night kind of thing, just be careful, because rewards can get a little bit over the top, and they can have bigger consequences if they're not healthy. So, you know, a chocolate or two, not an entire bag of Valentine's Day candy or something, just as an example. Establish healthy boundaries. So when you're off duty, as much as is possible, you need to be unavailable. And I understand people's jobs are different and you may be on call, that's fine. But when you're not on duty or you're not on call, you need to be off and unavailable as absolutely much as possible. That off time needs to be protected, because that is the number one thing that prevents burnout and restores people in these leadership supervisory roles and in frontline workers. Share your concerns, participate, talk to colleagues, talk to management groups, have a go-to colleague or person that you can kind of bounce ideas off of. One of the biggest risks with compassion fatigue is withdrawal. We shut down, we don't participate. And then people use passive coping like substances, and that becomes very dangerous very quickly. And then the fourth piece, which is probably the hardest one, is to trust other people, right? There is a myth, it's a medical myth of indispensability. They teach in medical school, where you believe you are the only person who can solve this issue or work this problem through or help this patient from beginning to end. And it's a myth for a reason. We need to be able to ask each other for help and to say, I can't right now, and to reach out and figure out what your other resources are when you know you need to have a little bit of a break. Okay, and finally, these are the ingredients of resilience. I just always like to include these because I think it's a good reminder. So purpose is about reorienting your motivation, right? Connection is about anything that prevents you from being isolated. Adaptability is learning how to shift your thinking from a threat to a challenge. And when you do that, hope is the byproduct. I want to acknowledge also that hope is one of these ingredients. Hope is the ingredient of resilience that is the most tempered by cultural experience of discrimination and racism and marginalization. It is much more, I should say it's easier for some people to feel sort of innately hopeful based on their cultural experience than it is for others. So hope is one of those that is very, very strongly tempered by our cultural experience of what we've lived through. But it's possible to connect with all of those things. I just want to acknowledge that about where hope is coming from. And then here's the last takeaway that I want to leave you with today. When you think about vitality for you personally and as a leader, try to identify just 3 or 4, maybe 5 core values for yourself. I'll give you some examples, right? The ones that I'm working on as a clinician and as a mom are gratitude and patience. Those are the 2 that are at the top of my list right now. And what I want to consider is how to practice and manifest and demonstrate that value in my different roles, right? At work or at home. What are my opportunities for that from when I get up until I go to bed? And I want to encourage all of you to try to consider where your opportunities lie to really ground your choices in 1 or 2 basic core values for the next couple of weeks. See what that does in terms of giving you a foundation from which to operate. Because oftentimes in recovery from such a large disaster, we're sort of at sea, we're sort of floating around and not feeling oriented. And this really will help ground our decision-making and our direction that we're taking with things. When we interact with other people, if I interact with my kids and with my clients and my colleagues from a place of patience, I can guarantee you that those interactions are going to go better than if I'm not grounded in my attempt to be more patient. And with myself, right? So I'm just using that as an example, but whatever your values are for you, orienting around that is often very helpful. And that is it for the slides. So I'm going to stop my sharing and I'm going to try to address some of the questions in the chat or in the Q&A.
Oh, wow. It is amazing. I wanted to make sure that we had time to answer these questions as well. So I'm really glad you got through what I know everyone could spend for a week at least. So let's start with the first question. Can you say more about sanctuary trauma and how it relates to the pandemic?
Yes, absolutely. Sanctuary trauma, for those of you who are less familiar with the term, is basically the idea that when attempting to seek sanctuary in what is considered to be a safe place, and typically that's not necessarily a political term, but in a medical facility or in a physical space or with people like doctors and providers who are thought to be they're supposed to be taking care of you. Like the way that the structure work is that you should be able to go and get help with something. That actually what has happened in the pandemic, especially for women and people of color, is that they have been disbelieved. They've been dismissed as those symptoms. That's not COVID, especially towards the beginning of the pandemic, or that there are lifestyle choices that are responsible for your symptoms. And there's a very, very discriminatory lens that is placed on evaluating the sort of truthfulness of people's symptoms and experiences. That has caused pretty significant trauma for large numbers of people. So there is actually some research on that. I can't give you a specific citation in the Q&A, but if you do some, even just a Google Scholar research on sanctuary trauma in the pandemic, there will be several articles that will come up. It is something that's being looked at more thoroughly as we move forward.
And as a reminder for folks, we'll certainly be putting together some resources and here to take on a couple of these items because you have a lot of knowledge. I hope Katrina's question got answered, but I want to make sure maybe we could restate it here. Is the H phase of the HEAL, which is the honoring, meant to be applied sometime rather than immediately afterward? I know there was a lot of discussion around this, so I just wanted to make sure that we heard your response to that if you wanted to share again.
Yeah, no, absolutely. There's no time frame for it, right? So if someone is not working, wherever they are in this process, there's no rush for that. It can happen at any point. And sometimes honoring the loss isn't necessarily a positive thing, right? It's about just the acknowledgement of whatever whatever the loss may be. So sometimes folks are not going to get there, and sometimes they'll get there much farther down the road. Yeah, no time frame for sure. Yeah.
Another couple of questions really relate to debriefing. So, one is asking their resource around group debriefing being contraindicated, and then more about research, perhaps. So maybe you want to.
Yeah, there's actually plenty of research about this. So critical incident stress debriefing and CISM, those are things actually that I was previously trained in or have been trained in. And what ended up happening is that initially it was one of the only options, right? It was like, this is what we do. When there's a large scale disaster, you have a facilitator who comes in and people are required to participate in group debriefing. What ended up happening is that as more and more research was being done in different formats with different types of groups that weren't homogenous, that had different structural elements and different sort of cultural pieces too, like the more research that was done, it became very, very clear that there are certain populations and certain circumstances under which critical incident stress debriefing and management actually is recommended. But by and large, the results are either neutral and can be contraindicated because it can create secondary harm. It can create more PTSD or the likelihood of additional trauma for people who are being forced to participate in something where they're not, either it's not safe for them to do it, and then they're being asked to disclose something in front of a supervisor or a peer that's not safe for them. So it's not by and large something to just throw away, but the idea is that if it's done, it has to be done very, very well with a highly trained moderator for a group and under very specific circumstances. It's not just a intervention that people should do and require of groups. So the research is out there. There's lots of things you can find.
I mean, yeah. So can you, maybe you mentioned this, but can you speak to, in my experience, sometimes something has happened and you need to figure out the series of events. You need to understand the points in time. You're trying to understand, maybe a crisis occurred, an injury, or some kind of, critical incident. Are these kind of different things where a more intensive debrief is more on the emotional level versus the facts?
Yeah,
I think that's something that I think has always confused folks. But because sometimes it's important, right, to get that information right away. But you also have to then be extremely sensitive to those that just went through this versus, okay, now we've sat on it. So I don't know if you can speak to that.
Yeah, there is a difference between requiring people, that's the mandated piece that's very, very tricky, sharing an emotional experience about what you went through versus reporting the facts about what happened for a report because either the law requires it or something systemically in your organization requires it. Those are very, very different things. So what I am referring to specifically is critical incident stress management or critical incident stress debriefing as a specific and very, very structured intervention tool versus, if you're being asked to say, give me the details of not the details, but report out on A, B, and C. I don't want to, hear this is not the space for how you're feeling about it, right? Those are different things. Now, I will say that both of them have to be managed very delicately, very carefully in order to be done well and effectively, but they're different things. So it's not, the one to be careful of is the emotional processing. You don't want to open that up for people in a space where it's not safe for them to do so.
Yeah, and I think in my experience, maybe HTCs or programs are not clear which one might get a little blurry, and then that can open up things, perhaps. So I know Joanne has, do you have info on vicarious trauma? I think probably, again, we can add that to the list of, if you have any key resources that you'd want to share. How do you support clients' grief and provide hope without it coming across? It's an interesting term. I just heard maybe more of this week. Without it coming across as toxic positivity. Yeah. So
I would say the difference between, toxic positivity is very, very popular as a topic right now in general. I also, the difference in my clinical opinion between toxic positivity and support for people is genuineness. Toxic positivity is disingenuous. It's trying to put something on or create a scenario or put a spin on a personal experience that is not consistent with what that person has lived through. That's when it becomes toxic, right? That's where the line is. So genuine discussion and active listening, that's not supposed to be directive anyway. And toxic positivity sort of gives this impression of putting on a lens on somebody else's experience. You're telling them how to think or feel about what they've lived through, when that might not be at all consistent with what their experience has been. And that's where the line has been crossed. So yeah, it's not about that. It's about being open to and really listening to someone else's experience and not telling them how to feel about anything, because that's clinically not very wise anyway.
Right. Part. Kind of 101. So lastly, I think this is the last question we can take right now, but we really appreciate all the discussions. It's fantastic. So what are some ideas for positive coping strategies to model for staff, especially in the office setting?
Yep, no problem. I love this question. Number one is structured time off and break times and boundaries. When you send emails, when you take vacations, when you're available and when not. That is the number one most helpful thing to model for people. Number two is to build in opportunities for connection. Connection is what keeps us going. And no matter how hard the work is, we will keep coming back to it when we have connection and we feel a sense of connection to either to leadership or to our colleagues and to our coworkers. People will stay in the fight alongside each other, right? So ways to increase connection would be making sure that even in a virtual setting, you're sharing information about what your experience has been, that you're sharing little things about your daily life that your colleagues and coworkers might not know, like a question of the day kind of a thing. I've made this recommendation a lot. Ask your colleagues to share, some random piece. Last week in our one of my DOH meetings, it was, what is your favorite dessert? If you could only eat one dessert for the rest of your life, what would it be? That seems so innocuous and so silly, but you learn things about each other that you would never ever bother to ask, because that is not an agenda item on a meeting, right? So for supervisors and leaders to build in those tiny opportunities for actually some fairly meaningful connection is helpful. The other thing too, and I mentioned this on the slides, is to structurally call out effort and success. Make time to acknowledge the good work that's being done, because we are so focused on how overwhelmed things are that we just don't internalize the good stuff. And there is so much good stuff that's being done. So that's something that as a supervisory position you can do to really encourage active coping and resilience for your teams.
Great. Well, again, we literally be here all day. I just, everyone's reactions to this content is fantastic. And I know we have to wrap up, but I know you're also here in a couple of days for what's more directed at direct service staff, but anyone is welcome. So we'll make sure to get that in the chat. I think Gabrielle's going to share screen again so we can get the eval. And sorry for the mix up. We're changing our evaluation processes. And so working through a little kink. So if you do not find the right survey, I hope you do, but you should be able to plug in this link into, we'll put it in the chat, but you can do just some feedback there. It'd be great to know how you receive this training. Next slide. Let's see, okay. And this is going to be pretty exciting for a lot of you. Apologies, I'm in a mildly loud place, sorry. But if you work in Region 10, so as we described in the beginning, we're from Region 10, Northwest MHTC. So some of our activities really need to be specific to that. But Dr Mossov is doing a learning community, and it's starting in, the end of this month. And so, you can find that, I think, on our website, or Gabriel will put that in the chat, and we'll let folks know. If you aren't in Washington, Oregon, Idaho, or Alaska, we won't approve you, and I apologize unless there's just not enough interest. But I already know there's twice as many people interested that we already talked about. So, and then we have another learning community coming up for supervisors. That's from another presenter we worked at, Rebecca Demerol. So again, we'll get some things in the chat so you can learn more about those if you're from Region 10. But Kira's doing another webinar in 2 days. Rebecca Demerol's doing some webinars at the end of the month. So lots of opportunities coming up. And then lastly, you know, if you aren't getting our newsletter, you don't know our website, I'm sure you probably do, or you wouldn't be here today, but we will certainly hope to connect with you in the future, and just thank everybody for their time. And thanks again, Kira, your information always lands just when it needed to. And yeah, it's fantastic material. And to the question about the evaluation, I think the evaluation should be in the chat. I hope the link is there earlier, just a minute or so ago. So hopefully that link works. Dr. Mossov, thank you so much for your time. Any words?
Thank you very much, everybody. I appreciate your time and all of our support of each other right now in this time. I think it's awesome.
Absolutely. Yeah. And we'll probably need to have you back about 100 more times. So thank you, everybody. Have a good rest of your day. Thanks for all your active participation. Thank you so much. And